Good evening, everyone, and welcome to today's webinar on what's new in flu, current challenges and management options. For this webinar today, we have with us our guest speaker, and I would like to take a moment to introduce him. Today, we have with us Dr. Pramod Jog. Dr. Pramod Jog is a pediatrician and neonatologist from Pune and has an experience of 38 years in this field. Dr. Pramod Jog is a professor of pediatrics at Dr. D.Y. Patil Medical College, Pune. Also, Dr. Pramod Jog was an ex-president of Indian Academy of Pediatrics in 2016, ex-steering committee member of International Pediatric Association and ex-steering committee member of Gavi. Dr. Pramod Jog practices at Jog Children's Clinic in Pune, and he completed his MD Pediatrics as well as MBBS from BJ Medical College, Pune. With this introduction, I would request Dr. Jog to start our webinar for today. Over to you, sir.
Thank you, Manohar. Thank you very much. I hope I am visible and my voice is audible. Is it so? Fine?
Fine, sir. Fine.
Yes. Okay. So now today we are going to discuss on what is new in flu. Remember that flu is a very naughty virus. Okay. And just as, many people change with time, this flu virus, influenza, as we call it, changes every year in its structure. See, this virus has two glycoproteins on its outer surface, okay? And they are hemagglutinin and neuraminidase. In short, we call it as H and N, okay? And they have those amino acids which show a bit of a change every year. And this gives a lot of problems to the people who manufacture the vaccines. So the WHO, the World Health Organization, collects the data from all over the world and finds out which are the prevalent strains and then directs the vaccine manufacturers to produce the vaccine accordingly. And this is simply because every year something new happens in this particular influenza virus, and that is the change in the amino acid sequence. We are going to see a lot about this virus, and you can see the nomenclature of this virus. If you see, has different components. So you can see my name. Suppose I am Jog, I am from Pune, I am born in August, that is the 8th month in the year 1958, and my name is Pramod Prabhakar, PP. So in terms of flu, it would look like Z, that is the type of the flu virus, the geographic location, that is Pune, then the strain number, that is 8, the year of isolation, that is 1958, and the PP, that is the name of the virus. So ultimately, it comes to this particular short form. So you can try your own name in this way also after this talk is over. And as Manohar told you, I am the professor of pediatrics at a medical college in Pune, and I am the 2016 strain of IAP president. Okay. Now, recently, I had a 3-year-old boy who came to me with fever, cough, cold, and progressive breathlessness over 3 days. And this particular child was tachypnic. The respiratory rate was on the higher side for his age. Also, the saturation was 85% at room air. The blood gases showed acidosis. And obviously, this child, when X-ray was taken, was diagnosed as ARDS. Okay. And it was a respiratory distress syndrome. And we admitted this child to the PICU. We ventilated this child. This child received Oseltamivir and supportive treatment. Of course, when this throat swab report came, it was positive for H1N1. And this child was ventilated for 3 days and then he was all right. So when we were discussing about this case, we were thinking as to whether early use of Oseltamivir, when this previously healthy child presented with cough and cold and fever came, whether this Oseltamivir would have reduced the entire course of illness, and this progression over the 3 days was there, whether this treating clinician would have prevented this progression. Okay, so whether every patient of cough, cold and fever in the flu season should be given Oseltamivir upfront, particularly in the flu season. So we were having this confusion, and that's why I call it as confusion, because it was connected with flu. So we all should be aware about certain facts, whether it is bacterial or viral. Whenever a child comes with fever, cold, and cough, that's a common problem, whether it's viral or bacterial. If it is virus, which is the virus? Is it the rhinovirus? Is it the adenovirus? Is it the influenza virus? Is it the COVID virus? If it's influenza, whether this is H1N1 or something else, and whether I should start Oseltamivir upfront, and should I give every patient antiviral to play safe so that there are no problems? Because we all know that earlier you give Oseltamivir to a child with influenza or an adult with influenza, within first 48 hours, earlier is the recovery and the complications are less, hospitalization rate is less, and so on and so forth, including the mortality, which is also less. Okay, so we are going to see the challenges in understanding influenza and its complications and the clinical evidence of the use of Oseltamivir as while considering the recommendations for the use. So another small little very smart and a cute girl, about 5-year-old, recently came to my OPD, and when I was examining the child, she had a small little doll in her hand, and this small little girl was speaking to the doll and telling her, don't worry, fikar mat karo, ye viral hai, this is viral. So I started laughing, and I asked the mother as to why she is saying so. So mother told me that my daughter also knows that when doctor says it's viral, there is hardly anything to worry about and antibiotics are not required. I was surprised at the knowledge of this particular parent and the daughter who was simply 5-year-old. But my dear friends, the days have changed. When someone says it's viral, so many thoughts come to the back of my mind, whether it is plain simple rhinovirus, or whether it is dangerous COVID virus, or whether it is adenovirus which has changed its behavior, or whether it is something else. And that's why what we are witnessing in the post-COVID period is something that we must understand. What has happened is that in the last year, that is 2022, somewhere after June, July, and August, around that time, we witnessed what was called as hand, foot, mouth disease, HFMD. As soon as that particular, epidemic, so to say, was on the wane, there was RSV which came into picture, the respiratory syncytial virus. Then came the measles, in Maharashtra, it continued for quite some time. And then there was H1N1, and then there was adenovirus, and then there was H3N2, which still lingers on. And that's why parents keep asking me, Dr. Jog, what is this? Why so many viral infections are going on? We never witnessed this particular fact before. So I had to tell them, my dear friends, remember, during COVID times, all children were inside their house, schools were closed, and the viruses did not have an opportunity to attack children. And children, that's why, did not develop any immunity against these viruses. And now that children have started going outside, now they are witnessing all these problems and they are facing all the viral infections. And you will also agree with me that even older children are getting affected in those post-COVID viral surges that I'm telling you. Okay. So what is the typical picture in the OPDs, and what has been the picture over the last few months is that children are coming to us with recurrent respiratory tract infections. So the mother will come on 1st of April and say, sir, my child has cough, cold, and fever. As soon as the child improves, again on 10th of April, she will come and say, sir, again for 3 days, the child has cough, cold, and fever. Again, as this episode improves, mother will come on 20th of April and say, sir, again, my child has cough, cold, and fever. So these problems are coming up more often, and the interval between the two illnesses is also on the lesser side. Okay. We have also seen otitis media, which is also in more number as compared to the earlier years. We have seen adenoidal hypertrophy. And as I was talking to you about this influenza surge, it has been unseasonal. We never saw H1N1 and H3N2 in the months of March and April, okay? Because usually we say that influenza is a problem of monsoon and the post-monsoon period. Adenovirus, we never discussed so much about the adenovirus for so many years, but now we are forced to discuss about adenovirus because the nasopharyngeal swabs we checked were showing adenovirus to a great extent. And this adenovirus has showed varied presentation. What we knew was it produces fever, cough, and cold, that's fine. And our standard Nelson's textbook of pediatrics, when we read long back, it mentioned that it is one of the respiratory viruses which comes with non-respiratory presentations like mesenteric adenitis, hemorrhagic cystitis, and so on and so forth, even diarrhea. Okay. And this time, in addition to the respiratory presentations like exudative tonsillitis, then the discharge from the eye in the form of pharyngoconjunctival fever, okay, and then pneumonia, and some cases with effusion, it has showed all those presentations, and it has been a prolonged illness. Usually, it takes about 4 or 5 days for adenovirus to settle, but then this time it's taking 7 days, 8 days, and it's really, really tough for many of us to convince the parents that this is viral. Okay. And that's why I said in the beginning that now if someone says it's viral, I am always worried. And remember, this adenovirus and influenza and COVID, these three viruses have shown rise in the CRP also. So we were under the impression that only bacterial infections in majority of the cases lead to increase in CRP. But these viruses are also, increasing the CRP levels. And the nasopharyngeal swabs, we never thought of sending so many swabs so many days. But now these days, sometimes we are forced to send this swab. Why? Because in addition to the antimicrobial stewardship, where we don't want to use medicines, antibiotics unnecessarily, we also want to prove that this particular child has a viral infection so that we can limit the use of antibiotics. Okay. And there has always been a therapeutic dilemma. Why? Because just I told you that there are, incidences where we are forced to use antibiotics, where we are forced to use anti-flu medication, and we have to be very, very clear about some of these facts. You will also understand that over last few months, the metered dose inhalers and the nasal steroids, the use also has increased. Now, you will understand that this particular child, Viru, who also had a viral problem. The name of this child has been changed by me to Viru because it's viral. And he came to me with fever for 3 days, cold and cough going on again for the same period. And he was on the metered dose inhaler for the last 4 months. It was all well controlled. And he was given symptomatic treatment. And he came back after 3 days. He had no fever for a day, but again developed fever. In between, he was quite active. And then this particular child was labeled as a child with recurrent viral upper respiratory infections. As I told you, they have become more frequent. They are occurring at shorter interval. And whether we need to give antibiotics, the clear-cut answer is no, because this is clear-cut viral infection. And you have to be very, very firm, and you have to tell them and counsel the parents that these are viral infections. The nature of the virus probably has changed because of the COVID pandemic. And that's why you keep quiet till the child is PES, playing, eating, and smiling. You need not worry. Okay. Only thing is, tell them about the danger signals. Okay. Tell them that this child, in case if the respiratory rate increases, if the child becomes breathless, or if the saturation goes down. You see, during COVID times, we have been, one important advantage of the pandemic was that everybody started knowing about the red flags and maintaining the pulse oximeter. Okay. So in case if the parents have a pulse ox, it's well and good. So they can always use it, and you have to tell them about the danger signs. Now you must know that the different respiratory system parts are attacked by different organisms. For example, the nose is attacked by the rhinovirus, and nasal infections almost always are viral. The throat, when it produces tonsillopharyngitis, 70% of cases it is viral. Okay. The one which is connected with rheumatic fever at a later date, the group A beta hemolytic streptococcus, okay, which we studied when we were residents, that is the one which is responsible for the bacterial throat infection, which is known in 30% patients. Okay. Then otitis media and sinusitis are predominantly bacterial in 70% cases, while in 30% cases they are viral. Okay. And as you know, pneumonias to great extent are viral and to some extent are bacterial. And that's why you should know as to how to identify the enemies. So if the onset is with cold and sneezing, think of rhinovirus, okay, where there will be common cold, the upper airway will be involved, there will be either mild or no fever, there won't be any exhaustion, the child will be playing well. This could also happen in influenza or parainfluenza or the respiratory syncytial virus in majority of the cases. However, along with high fever, if there is predominant headache, muscle pain, and extreme weakness, okay, you must think of flu, particularly when the fever comes with chills, okay. If it's adenovirus, I just told you that there is pharyngoconjunctival fever, along with some non-respiratory manifestations like diarrhea or a mesenteric lymphadenitis or a hemorrhagic cystitis, where the child might have hematuria, okay. And under the age of 1, we are aware of bronchiolitis, which is produced by a respiratory syncytial virus. And if there is fever and dry cough, indicating lower respiratory involvement, along with loss of the sense of taste and smell, one may think of COVID-19. And our bacterial enemies, like the streptococcus, which affects the throat, produces follicular tonsillitis with a tender cervical node. But then, recently in an exam, one of the examiners asked question to the MD candidate and asked as to how will you differentiate streptococcal throat infection from adenovirus, because both of them produce exudative tonsillitis. And the answer that the examiner wanted was that if a child presents with tender cervical nodes, usually it is streptococcus. And if the throat appears quite bright, fiery red, it is usually bacterial, that is streptococcus. Adenovirus will not show some of these, presentations to that extent. And if the child has fever and grunting and tachypnea and, is producing sound something like, meaning thereby the child is in need of, oxygen, is trying to get it by grunting, okay, then you can think of pneumonia because of pneumococcus. And if the child is progressing rapidly with pneumonia and then effusion and then empyema, then you must think of the staphylococcus, which also produces pneumatoceles on X-ray. And then a child who is above 5 years with predominant cough, think of mycoplasma, where the signs would not be that much. Now, this information is very important when you come across a child with fever, cold, and cough, because this will give you an educated guess, because every one of us is not that lucky to have a nasopharyngeal swab facility in the city. Neither the patients are so rich that they can afford the nasopharyngeal swab. So a lot depends on our gray matter and our education and such programs which would, revise your knowledge of microbiology and their clinical association. So look at this child. I will show you some cases of flu. And now this 4-year-old child came with cough and fever and high-grade fever for 5 days. It was not settling with oral medicines. The pediatrician had started amoxicillin, but that also was not working. The child on admission had tachypnea and needed oxygen support. If you see on the right side, there is obvious infiltration of the lungs. And this was a child where the total count and the platelet count was also on the lower side. The liver functions were deranged to some extent. And the nasopharyngeal aspirate was positive for H3N2. And this was influenza presenting with low WBC count and low platelet count. Remember, my dear friends, influenza is a respiratory disease with a lot of systemic involvement. That's why the child gets headache, the child will have muscle pain, weakness, and so on. Rhinovirus, on the other hand, doesn't produce all this. It will produce simple runny nose. And as I told you, the child will be playing well without any problem, and fever also will not be that high. So whenever a child with fever, cold, and cough comes with, systemic involvement, and systemic involvement as told to you by severe headache, the parents will lift the child and bring to your clinic. Then you should think of influenza. Okay. And another child with H3N2, where the counts were normal and nasopharyngeal swab showed H3N2. Again, the child where fever was not settling for 5 days. Okay. And then another child where the counts were normal, but the CRP was 38. I told you some of these viruses, they do produce rise in CRP. And remember, you can also see the X-ray showing involvement of the right side and infiltration. And this 1-year-old came with fever, cold, cough, and he came convulsing in status epilepticus. The throat swab showed H3N2. By the way, I must tell you that whenever a child with respiratory involvement gets admitted to our hospital, it's our protocol to, send the nasopharyngeal swab to find out what is the type of virus. And we have different types of, panels. One of the panels is expert flu, where we find out only RSV and flu and COVID, okay, which turns out to be a bit cheaper. There are some others which give the entire spectrum of viruses as well as bacteria, but depending on the situation, we decide which panel is to be sent, okay. And this child, as I told you, turned out to be H3N2 on the nasopharyngeal respirate. The MRI showed non-specific encephalitis changes. CSF was normal and it was labeled as influenza encephalitis. This complication is very common under the age of 1 year. And this child, a daughter of IT sector parents. See, at my place, there are not many information and technology parents. And they are not only IT, there is information technology group, but they are also inquisitive and troublesome. Okay. So they will, come in their shorts, they will bang their laptop on the table, they will ask questions which, any, pediatrician may not be able to answer. So they'll ask, what is this? Then I tell them flu. Then what type of flu? Okay. Then how is it to differentiate from others, so on and so forth. Okay. So this is, a tough situation. So this daughter was brought for fever for 3 days with throat irritation, and then the examination was there, after 2 days. So the parents were after me to do something and give the daughter quick relief. Of course, I only gave paracetamol, even though flu and adenovirus were around. And they were always asking me whether I need to send CBC and CRP and throat swab, and whether I need to start empiric Oseltamivir. So, my dear friends, remember, never fall prey to the pressure of these parents, because clinically you are knowing that this is a mild infection in an older child. Maybe 7-year-old is not a very small, under the age of 2, yes, you will be worried. But remember, if on the other hand, there is a 3-year-old boy comes to you for cough for a week and high fever for 3 days, and there are crepitations, meaning thereby there is respiratory involvement, okay, and lung involvement, then you are justified in putting this child on amoxicillin. Of course, this child was admitted for persistent fever, and as he was admitted, he was put on intravenous antibiotics, and the CRP was normal. And as I told you, when we sent the swab, nasopharyngeal swab, it showed influenza A, and Oseltamivir was added. Now, the question is, when a child is brought to you with lower respiratory involvement in the form of crepitations, and at the same time, when you have influenza A diagnosed on the nasopharyngeal swab, what do we do? An ideal pediatrician will obviously stop the antibiotics, and you have to weigh the situation. It is not that adenovirus won't come with Streptococcus pneumoniae. It is not that influenza won't come with Streptococcus pneumoniae. In fact, 25% cases of influenza come with co-infection, and that's why they have Streptococcus pneumoniae, they have Staphylococcus, and so on and so forth. So it's an individual decision, and some of the clinical findings as well as the investigation reports, which will guide you as to whether you continue Oseltamivir alone or whether you continue it along with antibiotics. However, this particular chap, the younger SIP, comes to you with high fever since yesterday, and then you are fully justified in starting Oseltamivir, because influenza virus spreads very rapidly to all the people in the family. So the SIB who is in contact with the brother who has influenza, it must be treated with Oseltamivir. I will tell you that there is a concept called as R0 or R0, which indicates the spreadability of the virus. For example, from one child of flu to how many children this child will spread the infection. For example, measles, from one child with fever and rash with measles, how many children, will he spread measles, something like that. So for measles, for COVID, for influenza, there is a definite number which is called as R0 or RO. And for all these three infections, it's, not 1:1. That means one child doesn't infect only one, but it spreads more than 2, 3, sometimes even 8. Okay. And it depends on these individual viruses. So you have to be very, very careful, because it's the adults who spread COVID from them to children, which we witnessed during 2021 and 22. But it is the children who spread flu from children to adults. Remember that. So children are the ones who spread influenza more. And that's why you have to be careful when there are people like a father who is a diabetic, a mother who is pregnant, a grandfather who is asthmatic, a mother, grandmother who has a chronic kidney disease and who is on steroids or something or the other. So whenever there are people who are immunodeficient, you have to be very, very careful in the family, because in case if the children are not vaccinated, and if children catch flu, they can always infect those in the family. Okay. And that's why you must know the entire kundali of influenza. Kundali is nothing but KYC, as we present in the bank. Know your customer. Okay. So know your customer. That is influenza. Give what is the PAN card like? What is the Aadhaar card like? What is the number? So remember, it's an RNA virus. I told you all these RNA viruses, including COVID, are very naughty. Every year they change their structure. We have seen so many mutations of COVID, and still in some parts of our country, we are witnessing another variant now. Okay. And I told you that they change their structure every year. And these viruses, influenza viruses, have produced major global pandemics. In 1918-19, there was the pandemic which was called as Spanish flu, which took almost the toll on 500 million people. 1/3 of the population of the world was affected with this Spanish flu, and 50 million people died in that particular H1N1 pandemic. In 1957, it was H2N2. In 1968, it was H3N2. And in 2009, it was again swine flu H1N1 2009. Okay. So influenza periodically comes with major pandemics. Okay. And that's all called as a shift in the virus structure, which I will tell you in a minute. So this particular H3N2, which has been seen in last 2-3 months, it has been linked to the high fever and cough cases, and cold wave and the fog and the rising pollution have triggered the surge in the seasonal influenza cases. And we have seen that flu is now not seasonal, but it's a perennial condition going on all around the year. And H3N2 infection is now in the air. And in children, this infection is a bit dragged. It goes on for a little longer time. So whenever a child is brought with cough and runny nose, along with headache and pain in the muscles and also weakness, and sometimes with vomiting and diarrhea, you have to be very, very careful. But in the epidemiological situation around, you are fully justified in putting this child on Oseltamivir as the child presents to you, because earlier you treat these children, earlier they are likely to recover by 1 or 2 days. And our ICMR network has given us a lot of information about the type of the virus, which is H3N2, during the first 3 months of this particular year. And we have many healthcare related challenges, particularly related to influenza and COVID. So whenever you come across any of these viruses, which are driven by the droplets to the other people, you have to be very, very, very careful, because for all the precautions in the form of wearing a mask and disposing of the tissues and others is to be done very, very methodically. Okay. And some of the studies published in some reputed journals have shown that the influenza positivity has started with the onset of monsoon, and it peaks during the post-monsoon months. And the incidence of influenza and the related deaths has been increasing alarmingly in India. Now let us see something about the virus. And as I told you, it's one of the most common infectious diseases, and it is highly contagious and occurs in seasonal epidemics and manifests as acute febrile illness. Okay, it can cause mild to severe illness, and serious outcomes of flu can result in hospitalization and death also. Remember, there are 3 types: type A, type B, and type C. Type A is the one which is seen in animals as well as in human beings. And remember, it produces frequent epidemics. I told you in the beginning that every year they show some minor antigenic variation. The amino acid sequence changes, and that's why that leads to different strains every year. But the pandemic is due to a major antigenic variation. Okay. Suppose my name is Pramod, and suddenly someone changes it next year to Shekhar. Okay, Pramod and Shekhar, obviously these are not at all connected with each other. Okay, so this is a major change in my name. Okay, but if there is someone who is called Bhaskar, and if the name is changed to say Taskar, okay, then it is almost similar, a minor change. So that is called as a drift, which occurs every year along with influenza A. But remember, influenza A, as I told you, it's seen in human beings as well as in animals. That is why when the virus from the animals mixes with virus from the human beings, there is a mixing of these different viruses. I told you HN from, say, the birds and HN from the human beings. There is a pig or a swine which is in between, which acts as a mixing vessel. So it takes H and N from the bird, H and N from the human beings, and inside the body of the pig, there is a mixing. Just as we have bhel or jhalmuri, we have churmura and poha and dana and dal and so many things mixed together. So ultimately some new virus comes like H1N1, which came in 2009. Okay, so like that, you have a different kind of a virus which comes up, and that's a major change. It is called a shift, and this occurs not very commonly, but after every few years, as I told you, in 1918, then 1957, 1968, 2009, something like that. But influenza B affects only human beings. Okay, it doesn't affect the animals, and that's why there is no question of mixing, and that's why it doesn't produce pandemics. Okay, it only produces local epidemics. And Victoria and Yamagata are the lineages of influenza B viruses, and influenza C infects humans and swines, but it's generally a mild respiratory illness and not thought to cause epidemics. And the currently circulating human subtypes AH1N1 and AS3N2 are the subtypes of influenza viruses. And as I told you, people with flu can spread it to the others up to about 6 feet away. Okay, and flu viruses are spread mainly by droplets when people with flu cough or sneeze or talk, and these droplets land up on the mouth or on the nose of the people who are nearby, and they will be inhaled into the lungs. And that's why we should stay away from the infected persons, and in case if we are sick, we should also stay at home. This is important. And we also should wash our hands often with soap and water, because these viruses can sit on our hands, and most of the healthy adults may be able to infect other people one day before the symptoms begin and up to 5 to 7 days after becoming sick. But in children, the virus passes on for longer than 7 days, even up to 10 to 14 days. And that's why children are the major spreaders. Okay, remember, in case if you think of all the viruses in the respiratory system, which I told you, like the flu and the para-influenza and the RSV and the adeno and COVID and so on and so forth, even Rajanikanth will not be able to differentiate these different viruses because they produce their presentations so similar. Okay, and it comes to influenza-like illness, that is ILI or H3N2 or a severe acute respiratory infection or COVID-19, it is equally difficult. Okay, so fever and muscle pain and cough and weakness and sore throat, they are common in almost all of these. However, the loss of smell and the taste is common in COVID-19. Breathlessness also is relatively more common in COVID-19, and diarrhea is also common in COVID-19, and headache, as I told you, is more common in influenza. Okay, now just to make our management simple, there has been a categorization of the influenza-like illness cases. However, influenza, the virus itself, the disease itself, is the father of all those influenza-like illnesses. In what do you mean by influenza-like illness? It means that the child has fever, cough, and cold, and we really don't know whether it is influenza or something else. So, influenza is the major cause, as I told you, the father of all those ILI cases. But the point is that not the virus, but the warning signs are important. Okay, so if any of these ILI cases shows you fast breathing or cyanosis, or the child is not drinking fluids, or if the child is not waking up, not speaking to the parents, is so irritable that he does not want to be picked up, or the child has improvement in the initial symptoms, but again fever and cough have appeared, indicating secondary bacterial infection. So all these are certain things which are called as the warning signs. And the complications of influenza, I have just summarized them with the alphabet A. Basically, they are ARI, that is acute respiratory infection, which could be in the form of pneumonia or ARDS, acute otitis media, and absenteeism from the school as well as from the office, which affects the amdani, and that is the income, and then antibiotic abuse, because there is no way to differentiate viral from bacterial. people keep using antibiotics. Okay. But remember, in general, for the first 3 days, when the symptoms are mild, please do not use antibiotics. It is very important that you keep away from them when the symptoms are mild. Okay. Only when there is respiratory involvement in the form of increased respiratory rate, low respiratory tract involvement, and features of pneumonia, then of course you can refer to the guidelines and act accordingly. Now remember that the otitis media is seen in almost 10 to 50% of children, and the typical time of onset of otitis media is 1 to 4 days after the onset of influenza symptoms. Okay. Pneumonia. Now, primary viral pneumonia is common in children with underlying risk, particularly under the age of 2 years, those who have heart disease or some other respiratory problem. And it's usually with Streptococcus pneumoniae or Staphylococcus aureus infection. Remember that. And exacerbation of chronic pulmonary conditions like asthma, particularly beyond 2 years in the hospitalized patients. And respiratory failure occurs in 5% of these cases. And some children also show acute laryngotracheobronchitis. Some children have toxic shock syndrome, and then myocarditis and pericarditis as some of the cardiac complications. And as I told you, simple febrile convulsions, influenza-associated encephalopathy due to the cytokine dysregulation, acute necrotizing encephalitis, Guillain-Barré syndrome, aseptic meningitis, so many neurologic complications. And I told you about the muscle pain. It's all because of myositis, which is seen more with influenza B, and it's common in children between 6 to 9 years, more in boys, where there is bilateral gastrocnemius and soleus muscle involvement with bilateral calf muscle pain, which is severe, and inability to walk, and there is rhabdomyolysis, and hepatic involvement in the form of Rye syndrome, particularly with influenza B, when children with influenza are given acetylsalicylic acid. So remember all these complications, and accordingly, you have to monitor these children. And management of influenza, if the disease is of mild variety, then it consists of bed rest, increased fluid consumption, suppressants for the cough, and antipyretic analgesics like paracetamol, and non-steroidal anti-inflammatory agents for fever and muscle pain. But avoid aspirin, because as I told you, influenza, when you treat with aspirin, may lead to a syndrome called Rye syndrome. And most patients with influenza recover in 3 days, but the weakness may persist for years, if not for weeks. And then severe cases may require intravenous hydration and other supportive management. Now, the treatment with antiviral drugs includes neuraminidase inhibitors, and Oseltamivir is the most important drug that you must remember. As I told you that there is hemagglutinin and neuraminidase on the outer side of this particular virus, and neuraminidase is the glycoprotein which is critical in releasing the virus particles, also known as virions, from the infected host cell. The virus, as you all know, every virus is a perfect parasite. So it will require the host cell to grow and replicate. So when you see this particular picture, you'll find that there is a virion, and there is a release of new virions, and the replication of the virus continues, the upper portion of the picture. In the lower portion, you can see that the virion has not been able to release further virions because the neuraminidase inhibitors have blocked the neuraminidase, okay? And the viral replication has been halted. This Oseltamivir is a potent and a selective inhibitor of the neuraminidase enzyme of influenza virus A and B. And Oseltamivir is a prodrug. It gets converted in the active form oseltamivir carboxylate. This occurs in liver, and it inhibits the influenza virus replication and further pathogenesis. It prevents further spread of infection, and it is effective against all strains of influenza A and B, and including some avian strains and swine origin strains. Okay. Remember, this was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries. It is very important to know the dosage and the recommendations of Oseltamivir. In adults, the therapeutic dose is 75 milligrams twice daily, and the prophylactic dose is 75 milligrams once daily. Remember that those high-risk people in the family require prophylaxis. If you look at the doses in children, under the age of 15, we require 60 milligrams in a day, divided twice daily. Obviously, if you have a 30 milligram capsule, you will be able to give 30 milligram capsule, one in the morning, one in the evening, for children who are under the age of 15 kg for treatment. And for prophylaxis, you will be able to give 30 milligram capsule once daily. If the child is above 23 kg, the dose is 120 milligrams. That is 4 capsules of 30 milligram. So you can give 2 capsules in the morning, 2 in the evening for the therapeutic purposes. And that is why the new 30 milligram capsule which has arrived in the market is of great help, because it usually saves the money and it's very convenient to give the dosage for that particular weight range. Remember, the treatment must be started within 48 hours of the onset of symptoms, because then only the reduction in the duration of illness occurs. Okay. And this is only to repeat what I said, that for a child who is weighing 15 kg or less, the treatment dosage for 5 days, 30 milligrams twice daily, and for prophylaxis, 30 milligram once daily. And it's very convenient. There is no wastage, and it's also economical. There are various benefits of the empiric and the early use of Oseltamivir, which has been proved in different clinical trials. And in patients with influenza, Oseltamivir treatment reduces so many things. It reduces the lower respiratory tract complications, it reduces the antibiotic abuse, and also it reduces hospitalization. Remember, the severity of pneumonia because of H1N1 is also reduced. Remember, earlier initiation of Oseltamivir after the onset of symptoms, it reduces the occurrence and the severity of pneumonia and also shortens the hospital stay. Okay. Remember also that WHO has recommended empiric therapy strongly. That means treatment should be started as soon as possible, and the confirmation, the laboratory confirmation of influenza is not necessary for initiation of therapy. In case if the lab test is negative for H1N1 and it does not exclude the diagnosis in all patients, therefore, you have to give this therapy early. And if high-risk individuals have been exposed to a patient with influenza, you have to consider presumptive treatment with Oseltamivir. And even Government of India has suggested empiric therapy with Oseltamivir. And even for adults with proved H1N1 or H3N2 infection, you can use Oseltamivir on empiric basis. So, my dear friends, remember that influenza is showing unusual pattern. Majority of them are H3N2, some of them are H1N1, and some are influenza B. The proper diagnosis can prevent flu complications, and even the early treatment can prevent flu complications. The empiric use of Oseltamivir reduces the lower respiratory tract complications, hospitalization, and antibiotic use. And many reputed societies have recommended the empiric use of Oseltamivir. A word about flu vaccine. Remember that this small little mnemonic Nescafe, Nescafe, will help you to assess the need of any vaccine related to any particular disease. Whether flu vaccine is needed, yes, obviously, for all the reasons that I told you. Whether it is efficacious, yes. Whenever the viruses in the atmosphere, they match the viruses in the vaccine. And when the match is good, the efficacy is bound to be high. Is it safe? Yes, it is quite safe. Is it cost effective? Yes. Is it affordable? Yes. Is it feasible? Yes, it can be given in the first year of life when the immunization schedule already is being followed by the parents. So we give 1 dose of this vaccine when the child completes 6 months, second dose when the child completes 7 months. And is this vaccine epidemiologically relevant? Yes, of course. And that is why many times we come across parents who bring the child in a particular month. We have to see the strain which is available at that particular moment. I had just told you that influenza is common in the monsoon and the post-monsoon season usually. And the southern hemisphere strain is available just before the monsoon right now also. So that could be given to majority of the children. Of course, some areas like Tamil Nadu and Jammu and Kashmir where monsoon sets in little late. And that's why in December when monsoon begins, before that in October and November, you can give them the northern hemisphere strain. And I told you, annually, it has to be taken once in a year. After the initial 2 pricks, when it is given in the first year of life, you have to give annually 1 injection. What I do is, to all the hospital staff, I give them flu vaccine on their happy birthday. Okay. So I say happy birthday to you, and then I say happy birthday to flu. That is because it's very simple to remember one prick every year. Of course, when you give the vaccine for the first time, you have to give two pricks, because the first one acts as a priming injection, second one acts as a booster. So once the priming has occurred, then every year you can continue to give it once in a year. Okay. So my dear friends, remember that flu virus, as the name of one of the English movies was Fast and Furious, it very much applies to this virus also. The onset is abrupt, the transmission is high, the progression is rapid, ARDS sets in very fast, and the child is likely to have mortality very fast. And it's only Oseltamivir which can quickly control the progression of this particular virus in the body. Okay. Along with this, of course, remember that sanitization, mask, and social distancing, cough etiquettes, and the Hasta-pancha-s, the 5 sutras related to the hand, are very important. Like hand washing, avoiding the handshake, using the handkerchief, keeping other people at hands distance, and avoiding the touching of the hands to other parts of the face like the mouth and the nose and the eye. Okay. Always remember that namaste, that means the way of greeting others with folded hands, is the best. And even the West has now copied India in this particular regard, particularly after COVID. So with that, I also say namaste and thank you for a patient listening. If you have any question related to this particular topic, feel free to ask. One of our colleagues wants to ask about the blood report test and the correlation with flu. I told you some reports in the beginning which showed that some of these cases can have low WBC count and low platelet count. You know that lymphocytosis is very commonly seen in viral infection, but in case of influenza, remember the WBC count, particularly lymphocyte count, may go down. And if it is less than 15% of lymphocytes, then you have to be very careful. Because in 2009, when we had pandemic, all those children who became serious, their lymphocyte count was less than 15%. So we have to be careful. Okay. I told you that CRP can be high in a child with influenza, just as in a child with adenovirus, and also in case of CRP. Okay. So remember some of these points, and whenever you find time to go through the recent editions of the standard textbooks of infectious diseases in children, please go through the chapters of influenza, because they always keep showing you some different information every year, because the strains change and information from different parts of the world gets accumulated and it is reflected in the standard textbooks. So with that, Dr. Manor, in case if you have any other suggestion or any other information that you want me to share, please let me know. Otherwise, we will say namaste to our listeners.
Yeah, sir. So these are the only questions which I shared with you. And sir, once again, on behalf of Hetero Healthcare, I would like to thank you for sharing your enriching experience with the attendees. And I also want to thank you to all the attendees for sticking till end of this entire webinar. I hope whatever the information sir has shared in this platform will be definitely useful to all the attendees in their day-to-day practice.
Thank you.
Thank you, sir. Thank you, sir. Yeah.